Okay, we can go ahead and get started. Thank you everyone for joining us for this month's CTSC Spotlight Series. This is a recurring webinar that highlights the breadth of services and resources that are offered within our CTSC. So each of these sessions is designed to inform investigators, research staff, and community partners about the tools, support, and expertise available to enhance the design, implementation, and impact of their own research. Attendees will gain practical insights on how to access these resources, hear success stories from peers who've benefited from the CTSC support, and connect directly with CTSC experts who can help them move their projects forward. So whether you're new to the CTSC or looking to deepen your engagement, this series is a valuable opportunity to stay informed, inspired, and better equipped for research success. So for those of you that are not familiar with the CTSC, our goal is to improve the health of people who live in Northern Ohio and beyond by providing resources and services to our hospital and university partners, clinical and translational researchers and scientists and community members. The CTSC is currently doing this by focusing on these 5 key areas and initiatives. So these are resources and services, community engagement, workforce development, clinical and translational funding opportunities, and health informatics. And I want to just take a brief moment to introduce our presenters for today. So we have Dr. Murphy, who has her PhD in ecology and evolutionary studies from Case Western Reserve. After she completed her doctorate, she served as a faculty member at John Carroll, teaching both undergraduate and graduate courses in statistics, experimental design, and ecology. Since 2023, she's been working as a biostatistician at the Clinical Research Center at university hospitals, as well as in the CTSC. In this role, she supports research efforts across UH and its affiliates, guiding studies from the initial planning and design phases through data analysis and publication. And with her, we have Dr. Durieux, who is an experienced researcher and is currently the principal biostatistician for the CRC at UH. He has his PhD in epidemiology, as well as master's degrees in nutrition and dietetics, data science, and biostatistics. He has an extensive background in developing research protocols and statistical analysis plans, and has served as a co-investigator on several grants and has co-authored 33 peer-reviewed publications, and has presented at 28 conferences. His areas of expertise include mixed effect analysis of longitudinal and survival data and the application of statistical methods for causal inference. So with that, I will turn it over to you both.
Thank you, Mackenzie, and welcome everyone. I'm really excited to be here today to talk to you about Clinical Research Design 101. We're going to talk about some essential design elements and how to lay the groundwork for high quality studies in clinical research. So for today's presentation, I'm going to focus on a couple of things. The first of which is we're going to talk about why good study design matters. We're going to identify some common pitfalls that many studies fall into. We're going to talk about some essential design elements, such as the PICO framework, randomization, replication, and analytical tools that can help avoid those common pitfalls. And then we're going to do an overview of some common study designs in clinical research. Hopefully, if we have enough time, and I do think we will, we're going to do an interactive session using TriNetX to apply that PICO framework that we're going to talk about today. And hopefully that can be a little bit more interactive and help reiterate some of the concepts that we're talking about during the presentation. So, why does good study design matter? Well, good study design is the foundation of high quality research. It ensures reliable, viable results that are reproducible and able to be applied to the broad population. It helps improve patient care and improves medical knowledge while minimizing bias and error and simultaneously optimizing resource use and efficiency. It also helps protect all patients and participants who are in the study based off of safety and ethical standards. And ultimately, a good study design will support evidence-based decision-making, whether in healthcare, policy, or practice, so we can act on findings with confidence. Poorly designed studies not only waste resources, but can also mislead us, and we can draw the wrong conclusions from them, which can potentially cause harm if we're acting upon wrong conclusions. And so ethically, we owe participants within clinical research and within our studies to have good study design and respect their involvement. So one way to have a good study design is to avoid the common pitfalls. Some common pitfalls are confounding variables. So many studies can have confounders, confounding factors, confounding variables. Those all mean the same thing. And what that's representative of are factors that affect both the exposure and the outcome. Many studies also have what's known as selection bias. And selection bias means that the participants within the study are not representative of the population. Sometimes studies, and sometimes this is unavoidable, and we'll talk about that, is that studies suffer from small sample size. And when you have a small sample size, this leads to low statistical power, which can have and ultimately lead to unreliable results. Oftentimes, studies are designed without a control group, which can undermine or make it difficult to determine the observed effects and whether or not those are due to the intervention that you're studying or other factors. And oftentimes, studies can suffer from poorly defined endpoints, meaning their outcomes are not defined, or maybe they're not measurable, they're too subjective, and thus lack clarity and are not being able to be reproduced in future studies. And so we're going to talk about each one of these pitfalls in a bit more detail. So confounding variables are variables that influence both the treatment or exposure and the outcome. And as a result of that relationship, they can distort or bias the apparent effect that the intervention has on the outcome. As a result, that can lead to incorrect conclusions. So for example, if we study coffee consumption and heart disease, but ignore smoking, we might wrongly conclude that coffee is harmful when the real culprit could be smoking. And so you have to consider that additional variable of smoking in order to detect the true effect between coffee and heart disease. In clinical research, there are a lot of common confounding factors or variables that we see in studies. The most common of which is age, and then I would say followed by sex. And that's because we know that biological differences affect how disease progress and respond to treatment. Socioeconomic status is also a really important confounding factor that needs to be included, because this is going to influence a patient's access to care. And we also have to consider lifestyle factors: smoking, diet, exercise. Those are all extremely important, and if not considered, can skew the results. Selection bias is another common pitfall in many studies. And this happens when the study sample isn't representative of the target population, or the selection of participants systematically selects a specific group. For instance, if a hypertension drug trial only recruits younger, healthier patients from one local clinic, the results might not reflect how the drug works in older or sicker patients elsewhere. So avoiding selection bias is crucial to make sure our studies can apply broadly and more generalizable to the greater target population. Studies with a smaller sample size suffer from what we call low statistical power. And when you have low statistical power, that means we don't have enough power in the analysis to detect whether or not a true effect exists. And so as a result, the small sample size, what's usually happening is because we have too few participants, we have really high variability in our results. And so they're unreliable. And as a result, we're not able to generalize those results in our study. The problem with small sample size can be linked to a few things. First, it can be linked and worsened by patient loss to follow-up, right? Sometimes that's unavoidable, it happens. But it's especially problematic where participants who are dropping out of the study early, for whatever reason that might be, those who leave might be systematically different than those who stay. And that introduces what's known as attrition bias into the study. Now, there are cases where small sample size is unavoidable. Maybe you're working with a group of patients with a very rare disease. So that's unavoidable. You're going to have a small sample size. But what we can do is we can employ specialized designs and analytical methods such as bootstrapping to strengthen the study conclusions despite that challenge. Another common pitfall are studies that lack a control group. So a control group is essential because it acts as a baseline to compare against the intervention group. Without a control group, we can't confidently say if the observed changes we're seeing are caused by the treatment or just part of natural disease progression. And so it acts as a benchmark for those comparisons. The use of the proper control group in turn improves what's known as the internal validity of the study. And so the internal validity refers to the ability of the study to accurately measure the causal relationship between the independent and dependent variables. And so you want your study to have really high internal validity. So for example, if you are studying a new medication and you are seeing improvements in the patients being treated with that new medication, but you also weren't following a group of patients with a placebo medication, you're not actually able to draw the conclusion that medication is improving patient well-being or patient symptoms. You need that control group for that comparison to be made. Also, many studies can fall trap to poorly defined or vague endpoints. And so when study endpoints aren't clearly defined, it can be really hard to interpret or compare results, which reduces the reliability and the credibility of the study. It can also lead to delay or block of regulatory approval and limit how the findings can be used in real-world practice. And so that's why your endpoints in your study, your outcomes, need to be very specific, very measurable, and relevant to your study. Just because you can measure something doesn't mean you should if it's not relevant. And they need to be standardized when possible. So for example, if you are in a clinical trial for maybe a new depression drug or medication, and your endpoint is overall happiness without a validated scale, that doesn't mean much. That's extremely subjective. And it's also not reproducible for future studies because what your interpretation of overall happiness might be, or what one patient's interpretation of overall happiness might be very different than the next. And so you need that standardized scale in order to have a very good study design, right? So now that we're familiar with some of these common pitfalls that we see in studies, what are some things we can do to avoid them? Let's talk about that really quick. So there are some essential design elements that you can incorporate while designing your study to make sure that the results you get are high quality and that the design you're implementing for your study is reliable and you can be confident in those results. And so one of the things we can do is we can apply what is known as the PICO framework. We can use what's known as randomization. We can use replication. And then there's some analytical tools that are also available to us to help account for some of those common pitfalls. So let's talk about each one of these in a little bit more detail so that we can understand how incorporating them into our design element can help avoid those pitfalls we just discussed. for our PICO framework. So the PICO framework is a simple framework that helps you ask clear, focused clinical questions. It's foundational because it helps you identify who and what you will be studying. And it's an acronym. And so the P stands for population. Who is the target group of the study, right? I represents intervention. So what treatment or exposure is being considered? C is going to stand for your comparison or your control. So who are you going to use as your control group, or who is the comparison going to be composed of? And then O stands for outcome. So what are the expected results of the outcome? What are you going to measure in your comparison between your intervention and your control group? So let's apply this to a research question just to make sure that we're following along with how this can be applied. So our question is, does having diabetes influence incidence of infection after surgery? So here our population, our broad population, is patients undergoing surgery. We're then going to subset that population of patients undergoing surgery into two groups. We're going to have our intervention group, which is the group where diabetes is present, so they have that comorbidity. And then you have your second group, the comparison group, where are the patients who do not have diabetes, and so they do not have that comorbidity present. And then our outcome is clearly defined. It's infection after surgery, which is a yes or no. And so we're going to compare, does the incidence of infection differ between patients with diabetes undergoing surgery and patients without diabetes undergoing surgery? So it's very clear, it's very specific, and it helps design a high quality study. So this matters. Why does this matter? What pitfalls does PICO help us address? It improves study quality by providing clear study objectives with a control group and defined endpoints. And so it can help identify also eligibility criteria. So are there any inclusion or exclusion criteria that you need to consider when you're going through that process of identifying your target population, identifying your intervention group, and so on? So this framework is extremely foundational because it helps address confounding variables, lack of control group, as well as poorly defined endpoints, which are some of the common pitfalls in studies. The other essential design element that we can implement is what's known as randomization. So randomization is the process of assigning participants to an intervention group randomly, and it's critical for designing studies because it helps by ensuring participants are assigned to groups by chance, not choice, which helps minimize selection bias and balances known and unknown confounders. And so it really enhances that internal validity of studies. And randomization is especially crucial when we're talking about like trial studies or randomized control style trial studies. By incorporating randomization, it gives us the confidence that the effect we see, if we do see an effect, is due to the intervention and not some hidden factor that we aren't aware of. And so it ultimately improves that internal validity of the study. We also can incorporate replication as an essential design element to help improve our study quality. So a replicate is an independent repetition of the same treatment or condition in an experiment. And the more replication you have, this is going to increase your statistical power and the precision of your measurements in your study. So for example, if we have a study and we're measuring a continuous variable, let's pretend this is BMI here on our Y scale, and we have a study only of 10 participants, we see that the variation around that mean is much higher than if we had a study of 100 participants. And so increasing that sample size gives us a more precise estimate and less variability in our data, which will ultimately increase our statistical power. And so how does replication improve study quality? It confirms reliability and consistency in our results. It also reduces effects of change and reduces effects due to change or random errors, and it ensures broader applicability because we have more subjects in our study and enhances validity. There are a few analytical tools that we can use as well. The first of which, and I'm sure many of you are familiar with this, it's called a power analysis or a sample size calculation. And so these are very common, especially when you're writing a grant or you're submitting to the IRB. A lot of times those institutions want to see what's known as a power analysis to ensure that you are able to include enough participants in your study to have enough statistical power. And so a power analysis is essential for determining the number of patients needed in a study. And it is composed of three key components. The first of which is power. So power is the chance to detect a true effect. Typically in power analyses, we set the power to a minimum of 0.80, but it could be higher than that if you would like. Generally, the higher the desired statistical power, the larger the sample size is required. So do keep that in mind. The next component is the significance level. So alpha, almost always we use 0.05. And then the effect size is the third component. And so the effect size is representative of the expected difference between groups. And you can determine the effect size from a few different resources. So maybe you had a pilot study. That's where you could determine your effect size between groups. You can also look in the literature and see if somebody has published a similar study to yours or has looked at a similar comparison, and you can use the data that they have presented as your effect size. And if you aren't aware, maybe you're studying a very novel comparison and there isn't an example out there in the literature, you aren't able to run a pilot study, then there are standardized effect sizes such as Cohen's d that can be used in place of those for the power analysis. Most importantly, the power analysis that you use, that you run, has to be representative of the statistical analysis or the comparison that you're making. So for instance, in your study, if you know you're going to be running a paired t-test on the data, the power analysis that you run should be for a paired t-test. It shouldn't be for a chi-square test. And so there's specific power analyses for specific statistical analyses that you're ultimately going to use near the end of your study. One little tip I do have, especially when we're talking about small sample sizes, is when you run a power analysis, if you're expecting to lose patients to follow-up, maybe you're conducting a survey study and you're nervous that your response rate isn't going to be as high as you anticipate, you can add you can increase and compensate for that by adding 10% or more to your final sample size to help compensate for those dropouts and maintain your study power when you run those power analyses. The next analytical tool, and we have, and it's a very simple tool, but it's extremely important when designing good studies, is to have a statistical analysis plan. So a statistical analysis plan is a detailed plan outlining how data will be analyzed before the study starts. So this is critical. You're outlining exactly how you're going to analyze your data before you even collect your data. And why this is important is because it can help identify any pitfalls in your study early on, even before you collect data. So including, this could be confounding variables. Maybe you have too small a sample size. Maybe you didn't include a control group for those comparisons you want to make. Or maybe your outcomes are poorly defined. A statistical analysis plan can help identify that. It's also really important because it helps facilitate transparent and reproducible research. If you have a strong statistical analysis plan, that's going to help when it comes to your data collection and interpreting the results later on. So statistical analysis plan should be done before you're collecting data and moving on with your study. Another analytical tool that's extremely helpful for these pitfalls that we've discussed is what's known as propensity score matching. Now, this is more of an advanced analytical tool that will be done by a statistician. It's a statistical method to balance groups based on observed characteristics. So a lot of times those can be those confounding variables that we're talking about. And it can very simply, what it does is it matches patients with similar likelihood or propensity of receiving an intervention. And so one way to think about this is if you have your control group and your intervention group, what propensity score matching does is it finds the twin in that group. And if that patient has a twin, those two patients are kept in the study. And what that does is it helps balance those baseline characteristics between the groups and those confounding factors so that when you're interpreting your results and you're looking for the association with those between your intervention and the outcome, you can be confident it's your intervention and not a factor that wasn't considered before. One of the things that propensity score matching is it can actually mimic randomization by creating those comparable groups that randomization itself actually does. And so this is a very short introduction to what propensity score matching is. And so if you would like to learn more about propensity score matching, we will have a CTSC Spotlight Series focusing on that on July 8th with Jared and I. And we're going to talk about propensity score matching methods, how to select covariates to go into that model, and how propensity scores impact the matched sample. And so if you would like to attend that, I have the QR code up on the screen. You can scan that and register today if you would like. All right, so we talked about some of these essential design elements, the PICO framework, randomization, replication, and analytical tools, including the power analysis, statistical analysis plan, and propensity score matching. And ultimately, what we do by incorporating these essential design elements into our study and into our plan, what we do is that helps avoid those common pitfalls of confounding variables, selection bias, too small a sample size, a lack of a control group, and poorly defined endpoints. Okay, so now that we've talked about some things we can do to incorporate, or things that we can do to incorporate into our design study planning to avoid those common pitfalls, let's talk a little bit about common clinical research designs. We're not going to go into too much detail. This is just going to be an overview of the most common designs in clinical research. So first and foremost, observational studies in clinical research. In observational studies, researchers observe and collect data on participants without intervening or assigning treatments. So there's very limited control in observational studies. And the main focus in an observational study is to show associations and not test cause-effect relationships. Observational studies are very good for providing real-world relevance, and they're ethically feasible. They're also very cost-effective and not too time-consuming. But one of the most important things that observational studies do is they help with hypothesis formulation. And so they help drive future research. Common observational studies include cohort, case control, as well as cross-sectional. There's also a few more, but those are the three most common. Experimental studies, on the other hand, involve actively assigning participants to interventions or control groups to test that cause-effect relationship. And so the key feature in an experimental study is the manipulation of variables and controlled conditions using randomization. And so by using randomization and manipulating variables, we can isolate the effect of treatments or exposures on the outcome. And so experimental studies have very high internal validity and test cause-effect relationships. Given that high level of control and the reduction in bias and confounding variables, experimental studies are kind of the gold standard for testing causality in clinical research. The most well-known is a randomized control trial. So let's talk very briefly about the three types of observational studies. So we have cohort study, case control, and cross-sectional. When we are talking about these three studies, they can be a little confusing. to kind of tease apart. And so what I really want you to focus on when you're trying to identify the type of study, observational study that you're conducting, is I want you to focus on the temporal variation. All right, and so what I mean by that is you need to focus on when the data is collected. Is it being collected over time? Is it being collected at one point in time? And that's going to really help you differentiate between these different study designs. So a cohort study, a cohort study follows a group over time to see who develops an outcome based on exposure. And so in terms of temporal variation, we have our exposure, we then have follow-up, and then we have that outcome over time. All right, so exposure, outcome. For case control, what we're doing in a case control study, we're comparing people with a disease, our cases, to those without the disease. Those are our controls, to find past exposures. And so in terms of our temporal variation here, we have our outcome, and now we're looking back in time to identify our exposure. And so it's retrospective. For cross-sectional studies, we're going to look at both exposure and outcome at the same time. So exposure and outcomes in terms of temporal variation are happening simultaneously. So there is no temporal sequence here when we're talking about cross-sectional studies. And one of the easiest ways to understand the difference between these study types is to use an example. So, for example, in a cohort study, an example of this would be we follow smokers and non-smokers over time to see who develops lung cancer. So this would be a cohort study. A case control would be compare lung cancer patients, cases, with healthy people, controls, to see who smoked in the past. So we would have to look backwards in time. Cross-sectional would be survey a population, a snapshot in time, to see how many smokers currently have lung cancer. Right, so these are the three most common types of observational studies in clinical research. In terms of experimental study designs, we have clinical trial, field trial, and community trial. So clinical trial tests the efficacy and safety of treatment or intervention in patients. So for example, new drug test, you're testing a new drug in cancer patients. This would be an example of a clinical trial. We also have what's known as field trial. So this tests an intervention to prevent disease in healthy individuals before the disease is there. So it's a prevention study. So an example would be a vaccine trial
You can
in
give
healthy
more
volunteers.
potato salad if you want, but
We
I think
also
too
have
much.
community trial where we can test interventions applied at the community to prevent or control a disease. And so, for instance, a sanitation program in a town to reduce infection rates. And when we're talking about these experimental study designs, they're all quite different from one another. So it's probably not very difficult to differentiate between them. But what you need to focus on here is the randomization. So all three of these experimental study designs implement randomization, but the way in which they implement it is at different levels. So for the clinical trial and the field trial, the randomization is occurring at the individual level. So it's the individual patient. While within the community trial, that randomization is going to occur much more broadly. It's going to occur at the community level, whether that's a town, a school, maybe a certain clinic. That is where the randomization occurs. So overall, observational studies, although they're limited in control, they represent real-world relevance and are crucial for hypothesis formulation and driving future research. The most common are cohort, case control, and cross-sectional studies, and they can be deciphered by focusing on that temporal variation, so when the exposure and the outcome are being measured, to identify and decipher between the three of them. Experimental studies, on the other hand, are the gold standard for testing cause-effect relationships, but they can be they're extremely costly and they're extremely time-consuming. They do rely on randomization at different levels to account for potential selection bias and confounding variables in their study. Okay. So now that we are finished with my presentation. I do believe we have a little bit more time. So just curious, how many people on the call today have worked within TriNetX before? And you can just like raise your hand or put it in the chat. Okay. A few. All right, so TriNetX is a great resource. What it represents is a health research network that aggregates EHR data from institutions into a de-identified database. We're going to work in what's known as the research network, which represents 106 healthcare organizations with over 148 million patients. So it's a large database of patient data. The type of data in TriNetX is demographic, diagnoses, procedures, lab results, and prescribed medications. It relies on medical coding. So one of the limitations with TriNetX data is that we do not have provider information, we do not have payer or cost information, and we can't query unstructured data. So if the question deals with like patient notes or something like that, that's not something TriNetX is capable of analyzing. In terms of TriNetX and whether or not you have access to that, what I would say is check with your respective institution. Or if you aren't sure exactly how to go about that process, you can reach out to the CTSC Informatics about TriNetX, and they can help you with that. So for our live demo of the PICO framework with TriNetX, what we're going to do is we're going to actually revisit that question of does having diabetes influence the incidence of infection after surgery? And so our population here, we're going to make it a little bit more specific just for the sake of time in TriNetX, because there's so many patients, it can take a long time to build these queries and run analytics. We're going to limit it to patients undergoing surgery on the heart and or the pericardium. Our intervention group is going to be the diabetes group. So they're going to have that comorbidity present. And our comparison is going to be the non-diabetic group, or the comorbidity is going to be absent. And our outcome is going to be infection after surgery. And so our type of study is going to be observational. It's going to be a cohort study. I want this to be a little bit of an interactive session. So I'm going to be in TriNetX building these queries, and I want you guys to kind of think about a few different things. So how should these queries be structured to ensure that they are independent, meaning that the patients in one query aren't also present in the other? That's extremely important when we're working online in TriNetX or any sort of online analytical platform. And then for the other things I want you to think about are what other factors should be considered when building the queries? Are there confounding factors that should be accounted for? Do we need to take into any considerations when defining our outcome? All right, and I'm going to give you a hint here. The hint is temporal variation. So think about that as we're working through these queries on TriNetX. And if you want to participate in the chat and kind of help me work through it, that would be great. But I can just, we'll go through it. All right, so let me make sure I can. I'm going to stop sharing my screen for 1 second while I get situated. Okay. Okay, so this is TriNetX. This is not the study I want. There we go. All right, so this is TriNetX. Hopefully everybody can see my screen. All right, so in TriNetX, what we have here, this is representative of the research network. We have 97 of the 106 healthcare organizations online. We could filter down if we wanted to look at to a certain age, or maybe we only want to look at males or females. We can then search by certain criteria to include in our query. And so the first part of the PICO framework is we have to identify our two groups, right? So we have our target population. Our target population is surgery, patients undergoing surgery for, whoops, TriNetX is not, there it goes. All right. So our target population is surgical procedures on the heart and pericardium. All right, so we're going to look within these 1 million patients, and we're gonna have to subset that group out into those with diabetes and those without diabetes. And so to do that, we are going to just look up diabetes. And include that in our query. And so here, what this query is going to do is it's going to search and filter for patients who underwent a surgery for the heart or pericardium, and they also have to have diabetes. And so if we look at this code for diabetes, it's going to include anybody who has type 1 diabetes, type 2 diabetes. If they have a medical code for a complication due to diabetes, it will include them. And all we do then is we count our patients, and we see that in our research network on TriNetX, we have 300,000 patients who meet this criteria. All right, so this is our intervention group. So what is our control group going to look like? What should we do? Any ideas? You can throw it in the chat if you would like. Any ideas? Okay, so our control group would have to be, right, because we have our target population. So we have everyone has the surgery. We've subsetted out patients who have diabetes. And now we have to have those subsetted out without diabetes. And so to do that, our query now is going to filter patients who underwent surgery and they cannot have diabetes at any point in time in their medical record. And so when we count that, which can take a minute, I had a feeling TriNetX was going to have trouble. It's been having trouble lately. So when we count that, we end up with right around 560,000 patients who underwent surgery but do not have diabetes. Okay, so now that we have our two groups, we have our intervention group, our exposed group to diabetes, and that other group who was not exposed to diabetes, we can compare them, right? We can run an analysis where we're looking and comparing our diabetic cohort to our non-diabetic cohort. And for the sake of this comparison, what I'm going to focus in on is I'm going to compare I'm going to look for the incidence of infection from 1 day to 30 days after their procedure, right? We're looking at infection. So if they have an infection 5 years after their procedure, we're really not interested in that, right? We can already say that those two things probably aren't related to one another. But 1 to 30 days seems like a very relevant time frame to look into when we're trying to quantify infection in these two cohorts. And so that's what this timeline is doing. And here, in order to quantify infection, all I did was I looked for infection following a procedure, which is a specific ICD-10 code that can be used. There's also a few other codes. So this infection following procedure isn't all inclusive of any infection that could possibly happen. So you would have to go in and probably include a little bit more, but for the sakes of this, we're just going to use infection following a procedure. And then we're going to calculate, we're going to pretty much perform a chi-square test, and we're going to calculate an odds ratio using the online analytics platform that TriNetX offers. And so what we would do is we would hit run. That's going to take a very long time. So for the sake of time, I'm actually going to bring up the results that I ran this morning, and I will show you those. So one of the things that's really nice about online TriNetX Online is you can perform propensity score matching. And so we talked about propensity score matching very briefly in our discussion before. And so what propensity score matching is doing here is it's balancing variables between our exposed diabetic group and our non-exposed control group. And what I had it match on was demographics. So I had it match on age, I had a match on ethnicity and race. I didn't include any other variables, just demographics for the sake of this presentation. And it performed that for me. And so before matching, we had 390,000 patients in our diabetic group. And after matching, we ended up with a right around 363,000. And we can see that that's the same case for our non-diabetic group. And so now we have equal numbers of patients in both of our groups. And so after matching, what we find is that infection within 30 days post-procedure is associated with whether or not a patient had diabetes. And so here we're seeing that the risk of diabetes is higher in our diabetic, or the risk of infection is higher in our diabetic group than it is in our control group, where they actually have significantly higher odds of developing an infection within 1 to 30 days post-procedure than our control group. Okay. Now, that's a great starting point, but this study is extremely simple. There's so many things we didn't consider, right? Is there anything you may have noticed as I was designing the queries that we should consider? So do we have any? No. Let me get back to my presentation. So think about that. Is there anything you noticed in the queries that should have been considered while we were designing? That's important. Yep. Smoking status is definitely a confounding factor. Whoops. Hold on. Share screen 2. There's my chat. There's my chat. Okay. So smoking status. Okay. Let's think a little bit more of, controlled or uncontrolled diabetes. That's also a very great point. So the severity of the diabetes, the exposure is going to be extremely important. Let's think a little bit more about temporal variation. So the query that I built was they had to have surgery and they had to have diabetes. But did I define anything about when that occurred? So they had surgery and they had diabetes, but did I say that the diabetes had to come before the surgery? I didn't. And so all that did was it said they had surgery and they had diabetes, but that doesn't mean that diabetes was actually already present when they went into surgery. And so we would have to go back in and we would have to make that definition a little bit more. Is there anything else you can think of that we might need to consider? If you have some confounding factors, so smoking status, whether or not the diabetes is controlled, any other ideas? What about the outcome? Can you think of something that might be important in terms of time? with the outcome, other than the 1 to 30 day time relevance. So what I was thinking when it came to the outcome was whether or not they had an infection before they went into surgery. So when was their last infection? Did they have one a week before? Did they have one, what was their status before they went into surgery in terms of maybe they were prone to them? Maybe they had tested positive for MRSA colonization, those kinds of things. So those are the factors you also have to consider. So one of the aspects of this framework that we didn't talk about was timing. Timing is an additional kind of optional when you're designing these projects using this framework, but it can really help specify the time frame for intervention. So making sure your exposure comes before your outcome. And it can also be really important when we're talking about the outcome itself. So are we looking at prevalence or are we looking at incidence? Also, are we looking at a chronic condition or a new condition? Something to consider when you're working within this framework. Right, so that is the end of our presentation for today. So if you have any questions at all, please let us know. Thank you.
Great, thank you so much. So if anyone has any questions, they can unmute or enter them in the chat. And then while people are thinking of questions or typing, I will just throw up a few more slides. So we just wanted to promote, Roberto has scientific writing open office hours that are every Thursday from 11 to 12. So you can see information here. And then we just want to thank both Jennifer and Jared for presenting today, and then be sure to register for next month's series. So you can use the QR code on the left. The middle QR code is if you want to submit a Spark request. And then of course, if you're not already a member of the CTSC, you can use for this QR code on the right to become a member. I'm not seeing anything in the chat. And I don't see anyone unmuted. So thank you so much, and I hope everyone has a great day.